So, good evening, friends. I'm Dr. Kaladhar from Yashoda Hospitals. Welcome to our Tuesday Masterclass webinar from the Department of Critical Care Medicine, Yashoda Hospital. We bring these sessions very regularly every Tuesday. The masterclass is devised in such a way where the two students of IDCCM, DM, DRNB, they present the live case in their ICU, and it is designed in such a way two expert examiners nationwide, they are involved, and they take us through this case and they give their insights, and these sessions are very helpful. So many students, especially during their exams, and they used to revise, and we get feedback very regularly, even from practicing intensivists and clinicians across even second tier cities, where they say these sessions are very helpful for their regular day in and day out practice. So this is near to 3.5 years. We post COVID we started, and without any interruption, it's going on. Thank you to Dr. Venkatraman Kola sir, who is the the mastermind behind these classes regularly happening. So with this, today's topic is septic shock and hemodynamic monitoring. So this is day in and day out very important core topic of critical care. We do see these patients very regularly. They have varied presentations, right from tropical fever to pneumonia to intra-abdominal infections, landing up in multiple organ dysfunctions, difficult to manage. Every individual differs in their presentation, and then the progress also. So there is a lot of research still ongoing, lot of papers, lot of evidence, conflicting things. These things will be discussed in today's class. So for this, I welcome Dr. Pradeep Rangappa sir, none other than, I think no introduction is needed. I think everybody knows sir is having a drpradeeprangappa.com website, and we do see these YouTube videos very regularly with very good updates. And the beauty of sir's presentation is he simplifies the presentation with very good graphics. So it's very catchy and easy to understand any difficult and complex topic. I do see regularly your classes, sir, and do get knowledge. And even the students are, I can say you disseminate the knowledge across. Very appreciate you, sir. Thank you very much for that, sir.
Thank you, Kaladhar.
Yes, sir. So I welcome Dr. Sai Prasad. Sir is actually head of the department and senior consultant from Yeshwantpur Manipal Hospitals. I forgot to mention that. And welcome to Dr. Sai Prasad, sir. So Sai Prasad sir is the director of Department of Critical Care Medicine, Diamond Super Specialty Hospital, Kolhapur. Sir is very active. I think since 15 years, sir is there in Kolhapur, and ISCCM, across ISCCM conducted many conferences there, and acted in like secretary and in different chairmen and different positions at Kolhapur. Thank you, sir. Thank you for coming on board, and welcome you onto our platform.
Yeah, Kaladhar, quick question.
Yes.
So, do you have a pattern that we intervene whilst they're presenting, or you want them to complete the presentation and then Sai and me?
You can interrupt the presentation
Okay.
at each slide, sir.
Okay, great,
and ask what can be done in
sir and Sai Prasad.
Welcome.
Yeah, Dr.
Hi,
Pradeep
Venkat.
sir, and hi sir. Good evening.
Namaste. Namaste.
Thank you.
Venkat. Yeah, good evening.
Good evening, sir. Thank you for accepting, and it is our privilege and honor to have both the senior seasoned examiners with us. Thank you for being a part of this program, sir.
Yeah,
and you can interrupt, and that should be like an exam flow, sir.
Okay, great.
Yes, sir. So for this case, I welcome Dr. Shravan and Dr. Shushmita. Both are our IDCCM residents at Yashoda Hospital, Malakpet, my students. So they present the case that what we dealt in ICU. I think Dr. Shravan and Shushmita, you can proceed with your presentation.
And live contacts or live questions, you can pick up, Kaladhar.
Yeah, yes, sir. Live questions will pick up and will tell to our panelists. Yeah, thank you. Yeah, please.
Over to you, sir.
Can I start, sir?
Start presenting, Shravan, Shushmita. Sai, you want to say anything?
No, let's start with the case. I think let them start with the case so we can discuss in between.
Yeah. Good evening, everyone. Would like to present today's case. The patient is a 50-year-old male patient with no known comorbidities. The former by occupation, He has presented to our ER with chief complaints of fever, abdominal pain, and decreased urinary output. Coming to the presenting illness, the symptoms were insidious in onset and they were progressive in nature. He had fever since 5 days. It was high-grade fever.
Around. You can speak a little slowly. Don't have to race. We have time, so you can just speak little slowly.
Yes, sir. Symptoms were insidious in onset and they were gradually progressive. He had fever since 5 days. They were high grade, measured around 1 or 2.5 degree Fahrenheit. They were associated with chills, and he was having headache and generalized body pains also. And other than that, he was having pain abdomen since 2 days, which was diffuse in nature, and decreased urinary output since 2 days. And there was no history of chest pain or vomiting or loose stools or burning micturition at presentation. Patient has initially went to the outside hospital with these complaints, where he was evaluated and found to have a severe thrombocytopenia of 21,000 per millimeter cube, and LFTs were deranged. So they've already they've sent dengue NS1, IgG, and IgM outside. They were found to be negative, and patients were referred to our hospital for further management. Coming to the past history of the patient, he has having no history of previous hospitalization or no known comorbidities. Personal history, he was a farmer by occupation, and his bowel and bladder habits are regular and mixed diet. He was occasional alcoholic, but not a known smoker. And there were no similar complaints in the family also. On examining the patient, he was having pallor and icterus, and there was no cyanosis or clubbing or no generalized lymphadenopathy or no pedal edema. He was moderately built and well nourished. And coming to the systemic examination, on inspection, the abdomen was slightly distended, but umbilicus was inverted, and there is no localized swelling or any discoloration or pulsations. And there are no superficial scars or sinuses, and no directed superficial veins or no visible peristalsis was seen. And on palpation, the temperature was normal. There was no rigidity or guarding. Diffuse tenderness was present on palpation, but there was no noticeable organomegaly was not there. And when we have percussion, the tympanic note was elicited, and bowel sounds were also heard. And bilateral chest movements were symmetrical and regular, and bilateral air entry was also present. And occasional crepes were seen in the bilateral basal areas. And it was a tachypneic presentation also. And there was sinus tachycardia was seen. Sinus tachycardia was noted on auscultation. Regular rhythm was present, and there was no murmurs heard, sir. He was conscious and obeying commands. And there were no focal neurological deficits also, and his higher mental function was normal. He was obeying. And so when he presented to our ER, his temperature was 101 degrees, 101.5 Fahrenheit, and his heart rate was 120 per minute. And it was regular rhythm, and peripheral pulses were feebly felt. So on BP measurement was showing 60 mmHg systolic pressure, and the capillary refill time was 4 seconds. So in our ER, 2 large bore 18 gauge IV cannulas were secured on the bilateral upper limb.
Dr. Shravan, can I interrupt you for a minute?
Sure, sir.
Yeah. So when he came to the ER, so what was your first impression looking at just his initial clinical examination?
Sir, he was having fever, sir. So it could be like any infections, infective etiology can be there, sir. And he was having pain abdomen, any intra-abdominal infective etiology can be there, so like acute pancreatitis or acute cholecystitis. Yes, sir.
Okay, what were the parameters you were worried about when you saw him?
Blood pressure, sir.
It was hypertensive, sir, on presentation. So, and it was capillary hypoperfusion was also there, so like capillary refill time was 4 seconds. It was prolonged. So
there was tachypnea also, sir.
Okay. Now, how do you prognosticate? You use any scores to initially look at these people?
we can use QSOFA score, sir.
Mhm.
In that, systolic BP is seen,
Mhm.
and tachypnea, I mean respiratory rate greater than 22 cycles per minute, and also
Mental status.
mental status,
Sensorial.
GCS.
Yeah. So the first initial assessment, I think respiratory rate is one of the important things you should have mentioned there, right? Because that is a part of QSOFA, which actually helps you to, I mean, at least understand the seriousness of this patient. You don't diagnose sepsis on the basis of that. So at least those parameters you need to mention in the initial assessment only before going to CRT and all, right?
Yes.
Yeah. And then any other scores you know of? Why you have to measure the QSOFA?
For admission into ICU, sir, like can be one of the scoring system for admission into ICU, sir, but it is not reliable according to surviving sepsis guidelines. Sir.
Yeah, alone it may not be sufficient to take any decisions, right? Yeah, please go ahead. So what about the blood pressure?
Just one question, Shravan, is what is the latest sepsis guidelines comment on QSOFA? Because we got a most recent guidelines, no, 4-5 years back. So
yes, sir.
Have they had any say on the QSOFA?
QSOFA score is not reliable when compared to other scorings are like NEWS, MEWS, NAWS, and CIS scoring, sir.
Although we may use it because it has been found to be having a lot of confounders and a lot of other medical conditions, and wrongly we may label as sepsis, albeit we have to at least factor in, as I said, tachypnea, low blood pressure, altered mental, they are all features of sepsis, and we may have to at least take note of it, but not necessarily we may be able to rationalize our treatment based on that, based on QSOFA. But at least it will tell you the severity of condition, and it will help you in prognostication also. QSOFA is a scoring for prognostication, that was an. But although people started using it for a screening for sepsis, the recommendation was against it to use it as a screening tool.
Yeah.
And another, just a quick question. So although you are presenting in a nice way, the typical way that you would want to hear from examiner, but do we really do all this in our ICU? Because even for as an intensivist, I have given few exams, I has given. Do we do such a detailed history? Because you said a lot of negative aspects, and you said percussion, palpation. So do we do that just in your practical day-to-day work in Yashoda? Would you do all that? Percussion and a lot of negative issues said.
Especially in an emergency room.
Yeah, because blood pressure is 60.
60.
Nice to hear all this.
Yeah.
But the point I'm making, Shravan, see, it is good now we are in a practice you are making. But suppose when you present like this in an exam, in any exam, in ICU exam, intensive care exam, even in Western exams, they wouldn't really appreciate, because as a physician, I may appreciate you have taken all this, but we would just want to hear the key positive aspects and talk about the urgency of the situation and highlight the severity of the condition upfront, rather than talking about all the other non-specific things which are not of relevance in this acute situation, isn't it? Because now this slide, what you're showing, makes most sense for me, because he's sick, he's very, very sick. And that possibly could be told in the upfront, saying on the background he's had all that, because multiple times I heard you saying he's a farmer. I'm not sure whether you are getting the relevance of his farming and some infection that he has later on. I'm not sure whether you're thinking of Brucella or Lepto or something of that sort. Otherwise, you can undermine certain things which may not have been very relevant to his current situation.
Okay.
Sai, any thoughts on that, Sai? Because Sai also is a physician.
Yeah, that's true. Actually, we are more worried about the clinical parameters initially, which are of more importance to us for immediate management of these patients. So my concern will be to rapidly assess tissue perfusion clinically. So that will be our purpose when you see this patient in an emergency room.
Yeah,
So
because all the juice of the information comes from this slide for me. Because you have nicely mentioned CRT, tachycardia, peripheral pulses, temperature, all the information possibly me and Sai need are in this. And you could have said on the background he's had all those problems. Comorbidities, he never had anything from what you said, isn't it, Raman?
Yes, sir. Yes, sir.
So had you said he's a very healthy guy, come acutely unwell with this on the background of this history, would have encapsulated the core essence rather than first 4 5 slides. I don't know what relevant information I got. Sai has any comment on the first 5 6 slides?
it's okay. I mean, they wanted to complete for
No, this is just
simply
a
sake.
tip I'm giving you, but it's
Yeah.
good. I mean, you're presenting in a detailed way. That's good. Since you're practicing, just a few comments to
Yeah.
make note.
Yeah.
Okay, sir. Okay, sir. Thank you, sir.
Yeah, now coming to this case, now this patient has is febrile, is tachycardic, BP is low, you say CRT is 4 seconds. How would you actually assess the tissue perfusion initially in emergency room? What are the clinical parameters you would look at to look for tissue perfusion?
Sir, urine output, sir.
One urine output,
Urine
fine.
output and mental status, sir.
Mentation, yeah, very good.
Mentation is one thing. And mean arterial pressure, sir. Mean arterial pressure.
Okay.
Yes, sir. And,
You have tachycardia is there, hypotension is there,
yes, sir.
tachypnea. So the another important thing is about the temperature, right? This patient is febrile, but it's always these patients, if the peripheries are cold on touch, maybe you look for the difference between the peripheral as well as the core temperature. So that also gives you an idea, right?
Yes.
And mottling,
Yes,
you
sir.
look at mottling.
Uh,
Probably in Indian patients, we may not be able to make it out so well. So these are some of the things you need to really look at when you look at these patients to look for tissue perfusion, right?
Just to add on to the question what Sai asked, how important is CRP, capillary refill time, in this present age, based on any recent evidence? Would you have any thoughts on that? And mottling, very beautiful question Sai asked. Is there any relevance to our intensive care domain as to the relevance of mottling, based on the evidence I'm asking?
CRT was in Andromeda trail. CRT was compared with Lactate, sir.
Okay.
So they have confirmed, they have postulated that during resuscitation, the increase in the CRT levels is more better prognostic factor than serial lactate measurements, like 20%.
Okay, good, good, well done. And what about mottling? Because you did mention, is there a score for mottling? That is one question. Second question is, which is the best site to look for mottling, and which is the most sensitive site that you look for mottling in a patient, and what does it signify in our critically ill septic patient?
Usually lower limbs, we see mottling in lower limbs, sir. And
Lower limbs is a big limb, no? It's a big limb. Exactly.
Where
Is there
exactly in
any-
lower limb?
knee,
sir.
sir, knee.
Knees.
Okay, yeah, it starts from the knee and it spreads around, and mottling score is based on the area it spreads
Area,
around
yes.
the knee. Okay, good, very good.
How it
And
is scored? 0 to?
0
0
to
to
5, 5, sir.
0 to 5.
and how about its relevance in critical care? Mottling, is it important at all from evidence standpoint? It is important. See, mottling, multiple studies, it's an indication of your microcirculation, because the signs you mentioned, tachycardia and systolic blood pressure 60, they are macrocirculatory index. So we do not have tools, major tools. Lactate is one of the tools for microcirculation, and mottling is an indicator of microcirculation. And there are studies to very clearly show its sequential relation to the mortality. And in fact, they're coming with thermal mottling, where they have a thermal sort of a instruments which can identify mottling even in a dark patient. So it is a way forward to determine your microcirculation is hampered. Your microcapillary circulation, there is microthrombi in your capillaries, because otherwise you have to depend on your sublingual sort of a circulation to ascertain the severity of microcirculation. So microcirculation is a big area. I think as a critical care specialist, you need to be aware of there's a lot of research happening with the parameters that you can use to determine the severity of microcirculation, and thermal modeling. We call it as thermal modeling now because there are thermal meters which are there which can identify this modeling. So hopefully we'll see very soon we may carry around these meters also. So it's an important marker of severity of sepsis and septic shock. So read about microcirculation. There's a big science in itself. Sai, any thoughts on that?
Yeah, that's right. Now, apart from the clinical parameters, now depending on the clinical evidence of perfusion deficit, you have CRT is more than 4 seconds. You have started to resuscitate this patient, right? Okay. Have you done the lactate level at this time, at this stage?
Yes, sir.
Yes, sir.
In latest
Maybe they'll come to investigation as we go.
Okay.
So blood cultures were sent. So you want to elaborate whether you sent one culture, whether you sent two cultures. Are there any sort of parameters that you'll bear in mind when you're sending cultures?
Two cultures were sent, sir, from the peripheral side.
Sorry, what do you say?
Two cultures.
2 sets or 2 bottles?
Two sets of culture sent.
Okay. From the same cannula or?
No, sir, different from the two peripheral sites, 2 sets of cultures.
Yeah. And how quickly were they sent, Shravan? Is that of importance to me and Sai when you're presenting? Blood cultures were sent, you have written. What if I say Shravan has taken history for 4 hours and is sending now blood cultures? Is that a reasonable statement to make, or
No,
would you package it better?
No, sir. On arrival, along with while starting the registration itself, we'll send the blood culture, sir. Ideally, should be sent within 1 hour, sir.
So we would have really appreciated, no? Me and Sai would have appreciated had you said blood cultures were sent immediately after clinically assess the patient. That would have given us confidence that you are paying attention to the guidelines and you are paying attention to the quick blood cultures that were sent. And I would have even appreciated, I'm sure you will tell me, that antibiotics were administered immediately after blood culture. Because these are very, very ultra basic things in sepsis that as examiners, I would like to hear at your level. If you don't tell me this, that I've sent blood cultures immediately whilst I'm taking the history, whilst resuscitating the patient, and then I've administered antibiotics, it gives a lot of confidence to me.
Yeah. Here, basically, is a patient in shock. So your resuscitation as well as the treatment should go hand in hand. I mean, it cannot be one after the other.
Yeah, that's a beautiful statement. That's a beautiful statement Sai is made. So everything is in concurrence. Everything is in concurrence.
Right.
Concurrently, things should be happening. And I see you in medicine. Me and Sai used to present these cases like this, that we come to treatment at the end, back end. Treatment, examiners don't even go to treatment. We'll stop at diagnosis only. But intensive care is not like that. Things happen together, concurrently. That I want to hear from the future champions of intensive care. That you are worried about this patient and you have to apply the principle of guidelines in your presentation. I want to hear that from you. Otherwise, how will I know what is the thought in your mind? What is the train of thoughts I should be able to appreciate? Just I'm giving you tips so that you make note when you're presenting. Because when you get an examiner like me, I will be worried if you don't, if you leave away these loose ends. We need to equip you with that. Yeah. Okay, continue. Go to the next slide. I think we're stuck here for a pretty long time.
Yes. Respiratory rate was 26 per minute, sir, and saturation was maintaining, sir, on 98% oxygen with face mask ventilation of 5 liters per minute, sir. And on initial GR-based measurement was 54 milligrams per deciliter. We have given a bolus of 25% dextrose. And on arrival emergency, we have done venous blood sampling, sir. And in that pH was 7.22, PCO2 was 29, PO2 was 40, sir. And lactates were 11.3, sir. So like showing like severe metabolic acidosis with high lactates, sir. Yes, with the respiratory compensation.
Maybe we'll stop here for some time to discuss about your parameters. So what does this all tell you? You know, because there are a lot of alarming variables that have come out, isn't it, in your test?
Yes.
So what does this indicate, Shravan?
Sir, patient is tachypneic, sir. Like he was having a respiratory rate of 26 per minute, and there was also hypoglycemic episodes are there, sir.
There is metabolic acidosis, sir. Severe metabolic acidosis. And
See,
So
my
if you want to
question is,
elaborate,
listen,
sorry.
here, see, now this is the first time we are looking at the lactate levels, right?
Yes.
So was this after resuscitation with 1 liter or 1.5 liters of fluid, and then you took the ABG, or was there a baseline lactate which was available for us for resuscitation?
So this was
Very good question. Very good question. Shravan,
So this was
I think, is that important? What is asking, Shravan?
Yes, sir.
Why is it important? You tell me.
So because like lactates are like targeting successful resuscitation, sir. Like
What do you call that? What do you call that word?
One or sepsis.
No, Sai asked you a specific question. Was this blood gas after resuscitation?
So this
No,
was
sir, this was
before
before resuscitation.
Okay, so this is at the admission.
Baseline.
This is the admission ABG which you are presenting now, right?
Baseline. Yes, sir.
Okay. So can you interpret that ABG? What is the cause of the severe acidosis? What are the different reasons for acidosis? So you had because at your level, I expect you, is it a high anion gap acidosis? And what are the significant contributors for this acidosis?
It is high anion gap metabolic acidosis, sir. And major contributors are lactates, and there is decreased bicarbonate value also in that, sir.
Okay.
Bicarbonate are 0.9.
And where do you think all these lactates are coming from, Sushmita?
Tissue hypoxia, sir.
Is that all? Is that all? Because from history, I think I could look at other pointers.
It can be tissue hypoxia, hypoperfusion, sir, or it can be like systemic sympathogenic stimulation and inflammatory response.
Tissue hypoperfusion I have taken. So in your own history, because I have not looked into any other test, you said something which tells me there is other contributor for this lactate. In your own clinical examination, there is another contributor for this high lactate. Is it something that is
decreased clearance is also one of the factors for high lactate?
No. Clearance is different. So let's not complicate. Here to my question very carefully. Hypoperfusion is one of the cause. In your own history and clinical examination, there was something that told me that these lactates may be coming from that also. What is that? And I don't get worried with this lactate in some common conditions I see in ICU. Sai and me treat them very often. We don't get too worried. They come with high lactate, and first thing we see is whether that is abnormal, and we say, okay, anyway, he has this problem, lactates are high, because this patient had that problem. What was that?
So fever, sir.
No. Fever. Does fever cause rise in lactate? So which means I have to ask you what are the causes of lactic acidosis? What are the types of lactic acidosis? How do you classify lactic acidosis? In exam, we will very quickly know how your thoughts are happening. Had you told answer for this, I wouldn't go into types of lactic acidosis. How will you classify lactic acidosis? You told me he had jaundice and he had liver dysfunction. So don't you think that is writing on the wall that liver dysfunction? And you told me he had icterus.
Yes.
And liver gives a lot of lactates, isn't it?
Yes.
And in ICU, if I have a CLD or a liver dysfunction, lactates will be high. Not necessarily they'll have acidemia.
Yes.
So why is it that didn't come into your mind? Because this we see. Sai, any comments?
Always keep in mind non-hypoxic causes of lactate rise whenever you interpret these things.
Yes.
Yeah.
Okay. So predominantly, there may be lactates coming from that also. Any other causes for lactic acidosis?
Is there a way of differentiating this lactate from other causes? Have you heard of have you aware of lactate pyruvate ratio? So because the pyruvate is not so commonly measured in many labs, but if you get that, if your lactate pyruvate ratio is more than 10 or less than 10, so you can differentiate. If it is more than 10, then it is suggestive of sepsis. If it is less than 10, again, it could be of some other origin. So this is one of the important things to differentiate in a emergency situation. Yeah, now how do you target this? Lactate is very high, na?
Yes, sir. Adequate fluid resuscitation should be given, so like to decrease the hypoperfusion.
Well, now the next important question is whether the resuscitation based on your lactate is better or based on your CRT is better.
Actually, CRT is better, sir.
Why?
It can easily be assessed
in the bedside.
Bedside assessment, and also in the study when they compared both rather than lactate levels, capillary refill time was more good for like decreased organ dysfunction.
In what way? And why is it so? See, you give some fluid, you target lactate. You give some fluid and you target CRT. So how CRT is superior to lactate? See, have you looked at Andromeda shock trial? So where they have compared fluid requirement and then with lactate targeted therapy. See, when you're using lactate as a target, you'll end up giving more fluids because lactate takes a longer time to clear, right? So even though you say at the end of 1 hour, if 10% decrease in lactate, it is a good prognostication and you are at the good resuscitation, all that, but lactate takes a longer time to clear. So you end up giving more fluids, but CRT is bedside, you can repeat as many times as possible and the effects are seen more rapidly. So there you end up giving less fluids there. So and the more fluid again leads to a lot of other problems later on, right? So that's why the lactate, instead of lactate, if you use CRT as a parameter, it will be better, right? But definitely you need to use lactate and then serially you need to measure to see that you are resuscitating properly. Yeah. Pradeep, you want to say anything?
I think, lactate, CRT, or we call it as a downstream indices of microcirculation. Along with it, I would suggest, Shravan, that you may have to look at your macro hemodynamics also. Like you have to obviously look at blood pressure, heart rate, urine output, mental status, so on and so forth, to make sure that your resuscitation goals are met. And I'm sure you're all good in a lot of fluid responsiveness strategies. So you have to look into later on, after your initial resuscitation, you have to look at your fluid responsive principles to guide your fluid resuscitations and early initiation of vasopressors. So that should be your overall sort of a ethos when you're resuscitating. So obviously, I think you had mentioned you have started norepinephrine. So we could possibly extend the question and ask at what stage would you add norepinephrine whilst you are resuscitating to attain your target goal? I think that may be a reasonable question to ask, isn't it, Sai?
Yeah.
Sir, it can use of vasopressors can go like hand in hand, sir. Like to main the target should be to maintain the tissue perfusion, sir. Map more than 65 mmHg, sir. So like there is a Clover's trial, sir, like where liberal fluid and restrictive fluid was compared. where there was no
Let
much.
us not go into trials because there are a lot of trials which, and our fluid resuscitation amount has significantly come down. But what does the guidelines now tell?
Sir,
Because let us stick to guidelines as a basic reference at this point of time.
So the question is clear. You want to, at what stage you want to introduce your pressors? So you want to give fluid and then wait for some time and then start, or you want to start simultaneously, or you want to give it sequentially? That's what is it.
I will start simultaneously, sir. I'll go ahead with the minimum vasopressin, minimum Norton requirement. I'll start like simultaneously along with fluid resuscitation.
See, the guidelines suggest, Ravan, that after your initial fluid resuscitation, you were unable to attain the MAP and your lactates haven't come down. So vasopressors could be initiated. So you don't need to keep on chasing the fluids because, as I said, you don't want to flood the patient because increasingly we have recognized too much volume also is not good. But having said all this, surviving sepsis guidelines, the most recent one, hasn't come down on the initial bolus. Even that we can be critical. When you talk about this Clover's trial and all, 30 ml per kg, if you are talking, so you are talking about 2 liters, nearly 60 kgs. If you take 1.8 liters, you are giving as a bolus. So that itself may be little more. So that is the argument that we could have as experts. But as of now, that initial bolus up to 2 liters, if you give, things are not getting better, lactates has not come down, then it is reasonable to start vasopressors and then keep continuing your resuscitative goals with fluids guided by your fluid responsive test. I think that is our understanding at this point of.
Sir, and in view of respiratory distress and persistent hypotension, sir, and the patient was intubated, sir, and started on mechanical ventilation. Initially, he was put on 100% FiO2, sir, with a respiratory rate of 30 per minute and tidal volume of 400 ml and PEEP of 6 centimeter H2O.
Yeah. So can I make one small little suggestion? It's good for all your global exams, any exams you give. We Indians tend to speak very fast. Try to learn little, talk little slowly. It's very important. Even I used to be like that when I was possibly at your stage. But what I have increasingly learned is when you start training more, go overseas, it is good to speak little slowly because Indians have a very fast the word rate. The word count is very high, and yours is definitely much higher. So speak little slowly. It is important as you evolve into future champions. It is good to speak little slowly because not necessarily I may be able to grab everything you're telling. There's no hurry. We are not in a hurry. There's no time limit. I've just come back from work, but I'm speaking slowly and I'm happy to engage with you.
Yes.
Even Sai is a very busy practitioner. I'm sure he has some 50 patients waiting for him, but so none of us are rushed. Why are you in a rush? I don't know if Kaladar has a time limit for us.
No, sir, not a limit, sir. You can extend if required up to 2
But
hours.
that's a honest suggestion. All of us should learn to speak a little slowly. It's important. It's good.
So, in view of respiratory distress and persistent hypotension and metabolic acidosis, rapid sequence intubation was done, sir, and the patient was started on mechanical ventilation with baseline settings of 100% FiO2, respiratory rate of 30 per minute, tidal volume of 400 ml, and PEEP of 6 centimeter water. Sir, this was the initial chest expression after intubation.
Just a moment. See, if, the narrative and the X-ray, it makes us hard to believe the corroboration, isn't it? Because you are put on a very arts net for a severe ARDS and PEEP also doesn't look appropriate. But I take your point. Maybe it was hypotensive. You didn't want to go up on PEEP. And the tidal volume at 400 for that lung looks little out of place for me. I don't know, Sai, your comments?
Yeah. And even on the ABG, the PO2 was so low. So,
That's venous sample.
Venous sample, sir.
venous sample, okay.
Yeah.
Okay.
You got our point, no, Shravan?
Yeah.
I mean, it may be, patient may be sick. I don't deny that, but it's just that they don't fall in place.
It's maybe because of the shock.
Yes.
Fine.
Sir, after fluid resuscitation, and BP was maintaining around 150 mmHg, sir, and with noradrenaline going at around 0.3 micrograms per kg per minute, and saturation was maintaining 100%, sir. And Foley's catheterization was done in the ER, and urine output was after catheterization 10 ml, sir. A loading dose of 2 grams of meropenem was given, and according to creatine, and injection doxy was given, sir, 100 mg. 12th early was started. And initial investigations which were sent are CBP, liver function test, renal function test, and prothrombin time with INR and APTT, sir. CE also was sent, and 2D echo and CT abdomen pelvis also done, sir.
Okay, we'll just take a little moment, pause here. Good, you have given antibiotics very quickly, and doxycycline appears very reasonable and good considering the acuity and the multi-organ sort of a picture with the liver dysfunction that you mentioned. Just I'm curious to know about the rationale for meropenem. So what was it in your mind as a source of infection that you had to initiate a high-end antibiotic, more so in the light of our stewardship principles we have to apply? Just curious to know what was running in your mind when you started meropenem 2 gram with doxy, because doxy is reasonable. You are thinking of tropical or some viral or atypical. All three, it is good. But meropenem, I don't know. Sai, what are your thoughts?
So,
Yeah, I mean, theoretically, what you say is right, but even I would have thought of meropenem because the patient is in shock and
fine.
we still don't know.
Taken meropenem, but what is it, Shravan, in your mind
Yeah.
that you had as a source? Whether
yes,
was it lung?
gram.
No, if you tell me, you convince me, sir, he possibly had UTI, he had a thick urine coming, whatever, first in the urine.
We have
Perfectly
not
taken.
we have not come to the what exactly the source clinically,
Yes,
right?
And then from history also, we didn't identify. I mean, what do you think of abdominal source? It's fine. Abdominal source you are given, I'm fine. Lung X-ray didn't show any patch to
yes,
say that he has developed some severe pneumonia or some in an immunocompromised sort of situation. What is it that should run in our mind when you give antibiotics?
sir,
He had pain abdomen, sir. Complaints of pain abdomen. So
Okay, so he did have pain
Cover-
abdomen, I agree.
and-
So you are thinking of some intra-abdominal source?
any abdominal
And
source,
source.
we have started a project.
Okay.
Meropenem.
So basically, you think of most likely source of infection and then the possible causative organism and try to cover it with a broad spectrum antibiotic, right?
Yes.
Okay. Okay, continue.
And in provisional diagnosis, we thought it could it as a septic shock with acute kidney injury, sir, tropical fever, acute cholecystitis, acute pancreatitis, urosepsis.
You had answer in the next slide, but you took time.
Yes.
Okay. I didn't pay attention to the creatinine. How much was the creatinine? It was not mentioned anywhere.
Yes.
Yes, sir, it was 3 milligrams per deciliter, sir. Initially.
Just go back to that slide.
Yes.
Okay. So bilirubin is very high, no? 6.6.
6.6.
HB was 10 grams.
Did you mention whether he takes ethanol? Was there in the history?
It was
any mention?
occasional. It was occasional
Occasional
alcoholic, sir. But not in the recent
Okay.
recent days. In the past immediate 1 week, he has not taken, sir. Like
Okay.
occasional.
Your total bilirubin is 6.6, direct is 3.5. What about the other? There is some 3.5 plus 0.6 will be 4.1, no?
Yes. I think so.
Creatinine 3. Yeah, 107. See, normally, if you look at that 6.6, the SGOT-PT is not very high.
Yes, sir.
So, mostly it rules out your viral hepatitis or ischemic hepatitis or drug-induced, all those kind of things. So, probably what remains is your
Obstructive
tropical illnesses only.
CT abdomen was done, sir, which showed a contracted gallbladder, thickened walls and thickened edematous walls. And in ICU, after shifting to the ICU, sir, the shock was worsening with map of 46, map of 46, and we have added vasopressin 2.4 units per hour, sir. And platelet counts were done, revealed 14,000, sir. So we have 4 RDPs were transfused, and arterial line and central line were secured, sir. And pulse pressure variation was 4, hence no further fluid resuscitation was done, sir.
Continue. Day 1 of ICU, he was on noradrenaline, sir, 0.3 micrograms per kg per minute, and vasopressin 2.5 units per hour was continued. And he had AKI with anuria. He was started on SLED for 8 hours, and ABG showed high anion gap metabolic acidosis. Injection hydrocortisone 100 mg IV stat and 50 mg QID dose was started. LFTs were elevated as shown. Lactates were 12.28, sir, and 2D echo, fair LV, no regional wall motion abnormalities. On second day, total counts were 25,470, sir. Platelets were 20,000. There was persistent fever of 101 to 103 degrees Fahrenheit. Lactates were 9.39. He was on noradrenaline 0.3 micrograms per kg per minute and vasopressin 2.4 units per hour, which was continued, sir. Slight improvement of metabolic acidosis was seen, sir. Second session of SLED was started as he was still oligurid.
Well, here, listen, Dr. Sushmita, you when do you actually decide to introduce vasopressin, and what else you want to look at that stage, or what is your take on adrenaline, epinephrine?
Sir, vasopressin can be introduced if there was requirement of noradrenaline of greater than 0.25 to 0.5 micrograms per kg per hour, sir. Adrenaline can also be used, sir, but there's more chances of tachyarrhythmias with adrenaline, sir. That's why noradrenaline is preferred.
It can be started along even with this noradrenaline vasopressin. If the map blood pressure is maintained less than 65 mmHg, inadequate perfusion, we can add on adrenaline, sir.
Okay, actually, when do you want to do a bedside 2D echo in these patients? What exactly you want to get? The other way around is when you actually want to, when do you want to stop giving fluids? See, you have not achieved MAP, right? 65 with noradrenaline. So when do you want to stop giving fluids? And you want any more information from cardiac side of it?
I think you did not show that slide, Sushmita. You crossed it before investigations. Yeah.
This was initial focus, sir. There was fair LV, no regional wall motion abnormalities. IVC distensibility index was 20%.
Okay, fine. So you look at the lung ultrasound. So this is one of the very important bedside tool which would really guide us about further fluid. And in the 2D echo, do you routinely look at E by E dash ratio? We do it routinely to give further fluid. Pradeep, you go look at that. E by E dash ratio, which will be, if it is more than 15, you don't give further fluid. That is one of the very simple bedside parameters.
We do all the
apart from
time.
lung profile.
No, we do, Sai. I think that's a very pertinent point. What Sai is making. See, CVP we say is obsolete. Obviously, none of us believe. But high CVP or like what is telling filling pressure, we look at LA pressures in your tissue Doppler. I'm sure you must be using that. So if you have a high pressure, obviously you wouldn't give fluid. At least it'll tell us when not to give. So CVP is definitely not is an obsolete thing. We don't rely on it to give fluids. But if it is high, obviously we wouldn't give fluid. Or if IVC is plethoric, we don't give
Don't.
fluid.
Yeah.
Or if filling pressure, what Sai is mentioning, which is left atrial pressure, we look at. I'm sure you will all be doing it with your tissue Doppler. If it is high, we wouldn't give. So it's an important tool to determine when not to give, as Sai is mentioning.
Because this is a time when actually we need to start restricting fluid. Otherwise, we may land up in trouble later. Right. So we have, go ahead.
Leptospira IgM was positive, sir. And we have started on benzyl penicillin 1.5 million units, IV 6 Starley, and the other tropical Paramax and negative, and scrub typhus was negative, sir. On third day, there was persistent fever, 102 to 104 degrees Fahrenheit. Total counts were 19,970. Platelet counts were 20,000. Lactates decreased to 6.33, sir. And acidosis was improved. SLED was started for 8 hours as he was still oliguric, sir. LFTs have improved. On fourth day, blood cultures were negative and acidosis improved, reduced vasopressor support. Vasopressin was weaned off, sir. And we have stopped injection meropenem and continued on doxycycline, sir. He was still oliguric, so we continued the SLED for 8 hours, sir, on that day also. And TLC count was decreased to 15,200. Platelets improved to 34,000, sir. We have stopped sedation. Patient was conscious and he was following commands. On fifth day, shock has improved, sir. Maintaining BP without vasopressor support. No further fever spikes were there. AKI still oliguric, no metabolic acidosis. Planned for alternate day dialysis, sir, for the patient. And total counts were 12,690, sir. Platelets improved to 52,000. He tolerated the SBT, sir. So we have extubated the patient. We have shifted the patient to ward on day 6. With the alternate, we have continued penicillin, sir, and doxycycline.
Go back.
So I missed few things. I was just getting phone calls.
Okay.
So what was the diagnosis finally, Sai?
Leptospira.
Okay, great.
Leptospirosis, yeah. So that's how they rapidly improved with specific drug therapy.
Okay, good. So lactate started coming down or didn't come down, Shravan? Because I wouldn't have expected it to have normalized because liver was giving all the lactates, isn't it?
Yes, sir.
Because your lactates are 12. You can go to the next slide, maybe. I don't know what. Second session, persistent fever. See, lactates have slightly come down. Whatever has come down, that would have been related to your hypoperfusion. Okay. So what did you give? Drug of choice?
Given benzyl penicillin, that's fine. It's now availability is a bit issue, but I think it's available still.
But Septraxone would have sufficed, no? It's easier one to.
Ceftriaxone would suffice. Any third generation cephalosporin would suffice. But if benzyl penicillin is available, that's a drug of choice.
No, Shravan, have you used benzyl or you made it up for this presentation? Because we
Yes,
all.
we have used
Huh?
we have given.
It comes by the name Jolly Bean, sir. Jolly Bean.
Yeah.
CP, crystal pencil.
Okay. And see, interestingly, you didn't. What is the next slide, Sushmita or Shravan?
Yes.
Because me and Sai would be keen about your ARDS ventilation you had put him on. So is that just an initial setting and then you rapidly came down? Because we would have loved to know what happened to all that settings you put.
Sir, actually, he was maintaining on minimal oxygenation only, sir. FiO2 per
you had put, is it?
sir?
You showed us those ventilation parameters, 100% and tidal volume of 400.
Yes,
So,
sir. After coming to ICU, there was a decrease in FiO2, sir. Like we have almost put him and on 60% of FiO2 and on day 3, 50% of FiO2.
okay. So now looking back, I stand justified, isn't it? Meropenem possibly has had no role, but did you de-escalate or did you continue? That's
Yes,
another.
sir.
We stopped.
For me,
Stopped injection.
that's good. You have mentioned that because I would have loved to hear that because if you had not de-escalated, it would have made me very uncomfortable. So on what day? 4th day you stopped. Okay.
Yes.
Because you got the result on day 4, is it? Leptospira report came on day 4.
Result came on day 3.
Okay.
Go back.
I can't see the date.
Actually, on the day when you started benzyl penicillin, you could have simultaneously stopped meropenem.
We were waiting for the blood.
Therefore, make a difference.
Waiting for the blood cultures, right? Probably they are waiting for the cultures.
Blood cultures.
Yeah, that's fine.
Once the blood cultures were
I'm okay
negative,
with
he was
it.
stopped.
From stewardship standpoint, my question to you, Shravan, is does stopping on day 3 and day 4 from the evidence standpoint, does it make a difference?
Like
So, but
no other.
have you done procalcitonin anytime in between?
No, sir.
Procalcitonin was not.
Because that's one of the important thing would have guided you further if you have done baseline and further also.
Yes.
Okay.
So what do you call this severe leptospira? I'm sure you would have read about it. With liver dysfunction, multi-organ dysfunction.
Wheel syndrome. Wheel syndrome.
Okay.
Leptospirosis with AKI.
Multi-organ dysfunction.
Multi-organ dysfunction, sir. AKI, liver involvement, and
bleeding manifestations.
Okay. So him being a farmer has some correlation with leptospira. How does it spread?
Usually through rodents, sir. It spreads through rodents.
Is it only rodents?
No, sir. Domesticated animals also it spreads through. They act to the reservoir.
So how does it spread basically? How did it come to this farmer? Did it come by inhalation or ingestion or by whatever? I don't know.
Coming in
or contact to these animals. How does it spread?
Urine of contaminated food with soil contaminated food, sir. Which are soil is contaminated with the secretions of the reservoir host and
how does it enter the patient here? How did it enter?
Any abrasions, cuts in the abrasions or cuts in the feet, contaminated water and skins.
Okay. Yeah, mainly the fecal matter or urine of the animals infected. Fecal-oral also it can spread. Okay, good. And is there a role for extracorporeal sepsis support in these patients? like cytokine removal and all that? Do you use that in your practice?
No, sir.
Good question. Is there any role of VA ECMO?
So if dialysis is not helpful, like he was persistent acidosis and no clinical improvement on dialysis, then we could think of VVA ECMO, sir.
No. VV ECMO, you think of when there is ARDS not responding, all those kind of things. Is there any role of VA ECMO? Because the patient is in shock. In sepsis, do you do VA ECMO? You don't do for correction of septic shock, no, unless there is a reversible myocardial dysfunction, right?
Yes.
Yes.
Yeah. Anything else, Pradeep?
Yeah, very good. I think it's a very easy peasy, straightforward sepsis. So what's the definition of sepsis, Shravan? Just to ask, because I have asked this in our IFCCM exam and I've seen candidates struggling. So tell me the definition of sepsis.
So defined as dysregulated host immune response
Sorry, no, slowly again. I want you to tell little slowly.
Sir, defined as a dysregulated host immune response to infection.
That's all. Shushmita, we want to better that answer. See, I would get very unhappy if the definition is not articulated. This has happened. If my IFCCM candidate was not
Life-threatening organ dysfunction.
Take a look out on that, Shravan. The whole ethos of our ICU is organ dysfunction. If you don't mention that and tell some jargon of dysregulated response, how will I know whether it's dysregulated response? It's an organ dysfunction, isn't it? It's a life-threatening organ dysfunction, secondary to possible dysregulated host response. So you cannot go wrong in not answering. If Sai is an examiner, you don't answer what is sepsis, then he would feel very uncomfortable passing you. So what is the 1 hour bundle in sepsis, and what are the key components of sepsis management in first 24 hours?
1 hour bundle fluid resuscitation with 30 ml per hour, sir. Initially send the lactate value. If lactate is greater than 2 millimoles per liter, then we have to repeat the lactate value after resuscitation, and obtain blood cultures and start on antibiotic as soon as possible, sir.
That's the first hour. Then what are the key things that you are expected to do in maybe next 48 hours? Everything is time bound, no, in sepsis.
Yes, sir. The tissue hypoxia should be addressed, sir. Like proper resuscitation should be done, and maintenance of MAP greater than 65 mmHg.
Okay, then. See, throughout the sepsis guidelines, I think the ethos, I'll give you two, three tips, is the source of infection has to be very aggressively identified within 48 hours, because there is a rationale for that. And in fact, if you read the guidelines, at least in 2-3 references, they keep re-emphasizing that if it is not sepsis, then you have to look at de-escalating antibiotics or rationalizing your antibiotics. That's why I think you have to be hyper aggressive as to whether you are rational enough to continue antibiotics or not. And day 3 and day 4, why it's important is all the drug resistance that evolves happens after 72 hours, because if you are indiscriminately giving antibiotics after, because studies have very clearly shown after up to 48 to 72 hours you have a ability to give at your own whimsical thoughts, but after that you have to be absolutely certain that the type of antibiotic you are giving and the dose you are giving is all calibrated to the answer with regards to the type of infection that you have. Because after 3 days, you give indiscriminate antibiotics, the resistance pattern builds up in organisms. So that is why the source of infection to be ascertained within 48 hours and eliminating the source is very important. Those are the goals in sepsis guidelines. Anyway, here the source, you got it within 72 hours, but there was no need to continue for day 4 when meropenem. Okay, and echo, someone has asked in the chat,
Yes,
could you please explain again why echo is not done in sepsis? Who said echo is not done?
VA ECMO, sir. That is actually
VA ECMO.
VA ECMO is not done in sepsis. Cyprus, sir, was
You asked the question. You want to take that? Someone is asked in the chat.
No. Basically, see, when VA ECMO is done for only circulatory failure, which is vasodilatory in primarily sepsis, if you do that, it's not shown any mortality benefit. So it is to be done only when there is associated septic myocarditis, or there is a complex etiology of sepsis where there is primarily cardiac disease also there, which myocarditis or some other reason, and along with that there is sepsis. So then you can still consider. Otherwise, doing primarily for sepsis related shock, VA ECMO has not shown any mortality benefit, because there it is primarily a vasodilatory shock, right? That's the reason.
Yes, sir.
Okay, good. I think we have had good 1 hour of discussion.
Yes,
So,
few questions.
Shravan, I tell everyone, now you presented, you knew everything. It's like a leaked question paper, right? And you knew all the answers, you prepared well. Even then, you saw there were certain areas where we could still sort of suffocate you. So you should go to exams that today you will easily pass the way you presented, but in exams you'll be performing at maybe 30% of what you presented today, because you won't know what case you will get, what case scenario you will get, and the pressure of exam and the cluttered thoughts you will have. All that will make you underperform. So be very clear whilst articulating, and obviously examiners can easily make out how well you are prepared when you're presenting the case.
Yes.
So go with that ethos, but well presented, and you could answer most of the questions. Sai, your thoughts, and we can close it. Kaladar.
Sir, 1 or 2 quick questions, sir. Like as Pradeep Nangappa sir was telling, so regarding extracorporeal therapies, most of the times this is a dilemma. Most of the people like what to start: cytokine filter, oxidase filter. There are any number, hemophil filter. So many things. We do use a bit of hemophil where it's cost effective. Sometimes oxidase filters with CRRT and all. So at which situation, like at which point do you think it's better to consider? Most of the times people have a dilemma about it once the patient comes. Of course, affordability and all other things issue. So can you enlighten a bit about it, sir? Pradeep, sir?
Sorry, I missed it, man. Sorry, can you repeat that?
Yes, sir. Yes, sir. Regarding extracorporeal therapies, sir, especially cytokine filters and all. At which time generally we use filters like oxidase filter, cytokine absorption filters, there are any number are there. So some people, they respond very well to these filters at initial presentation, even like dengue shock syndrome and all other things. So what do you think, sir, at which point, even plasma exchange in some cases they mentioned. So what do you think, how to generally rationally use these therapies to modify the
If we look into the body of literature, all the listeners, honestly, there's no robust evidence to say this has done a meaningful difference to the outcomes. If you look into some meta-analysis, point out towards signals, towards some benefit. But if you look at all the studies, the positioning is very early on. If you look at a gospel in sepsis, everything is early. And when you position this early, you don't know whether ordinarily they would have gotten better or whether this intervention has made a difference. So there is no robust evidence, but we use this as a desperate measures in extremely sick patients where all your initial resuscitative goals have not led to any meaningful outcome, and you are grappling with possible source that you could possibly fix. Then generally in our practice, we have used more of cytosorb, which is cytokine removal. So it basically has polystyrene fibers, because someone has asked in the chat what is cytosorb. So it's a polystyrene fibers which are meant to absorb all the cytokines, inflammatory cytokines. But we have used it. The cost is a factor, but it's not a standard of care. So for in the audience, in the exam, if they ask you this question, you can always substantiate what you do in your unit as a policy, and then substantiate that although there is no robust evidence, but as a desperate measure, we do use it, and there is a cost to all this extracorporeal circulation. But plasma exchange is little different, because there is a definitive positioning of plasma exchange in liver failure, acute liver failure, as a bridge to the transplant. And there are a number of emerging studies where in fulminant livers, your plasma exchange has shown to have a good outcome. So there are a lot of studies that are coming in, and we are increasingly using plasma exchange where predominantly we want to address the worsening liver function as a bridge. Even in acute virals, we have used it as a bridge before whether they go for transplant or things settle down, and generally liver functions also tend to improve. And there are a lot of filters also that are available now, which are meant to absorb the liver toxins. So that is how I would look at this positioning. So plasma exchange has a very distinctive positioning, not for all sepsis, mainly for the liver, worsening liver function and fulminant livers, as a bridge to either medical recovery or listing towards transplant. But cytosorb, it is your individual call as a desperate situation. Sai, your thoughts?
Yeah, that is true. We don't routinely use that, and even the guidelines really have not recommended. But people do use as a desperate measure, as Dr. Pradeep has said. You have to individualize and take a call.
Yes, sir. Sai, sir, just one question, what is the role of rapid pathogen identification, the diagnostic stewardship, like something like antimicrobial stewardship we speak? So more and more, you want to isolate the pathogen as early as possible and target the therapy. Most of the times we go with culture.
We find it very useful, especially these PCR-based diagnostic tools. They are very handy, and especially you don't lose that initial time, and you start the right antibiotic as early as possible. Even though initially they seem to be little expensive in the overall management, it does make a lot of difference, especially in patients of septic shock. I found it very useful, and we routinely go for it.
Okay, sir. So one question from chat box, is there any role for antioxidants in septic shock? So it's a broad.
Antioxidants, what? It's tablets, you mean?
No, vitamin C and other things.
So there's absolutely no role, no, because all studies have come and it's debunked.
Yes.
So there's no role, because there's a lot of vitamins trial. There's multiple trials that have come. Oranges trials, so many trials have come.
When our SCCM guidelines have clearly said no to all these things.
Yeah, I think that's a good point. In fact, the sepsis guidelines recommend against use of vitamin C.
Yes, sir. Pradeep sir, one last question, what are the newer advancements that you think, AI development? So many things are happening. So every individual responds to sepsis in a different way. Some patients, those who are young, respond very badly and they just die in front of us. Some elder patients, they come out. So this is always a paradox. Sometimes you feel bad. I think you are lacking in that area. So what do you think are the newer advancements that are going to come into picture? Probably.
Yeah. I think that's a very good question and very broad question. It's a broad, so I can possibly,
Yes.
We can create one CME on newer advances in CME. But just for the interest of audience, I think the key thing that you should all now appreciate in the advances in intensive care for all the listeners is the whole concept of critical care or intensive care is progressing towards phenotyping the cohorts of patients and phenotyping and genotyping. Genotyping, we are still not there. Phenotyping is something we are clearly understanding, because we are now trying to prognosticate the patients who respond to certain elements of treatment and certain patients who do not respond to the certain treatment nuances that we put in place. I think that is where we are heading. So to that effect, to give you an example how phenotyping is happening, in ARDS, there is a phenotyping happening as to who are PEEP recruitable, who are not PEEP recruitable. So in sepsis, what is happening? So there are at least 20 studies. I want you all to go and read. So people are doing HLA-DR as a marker. So HLA-DR is a sort of an element that they are looking at, or a variable they are looking at, to prognosticate which are the patients who do well, where HLA-DR are well represented or good levels, or suboptimal. And very clearly, all the studies done so far are very clearly saying HLA-DR being low clearly tells us that they are non-survivors in sepsis. So one of the markers. So like that, there are multiple things. They're even looking at the ATP production from the lymphocytes. So, and they're looking at interferon gamma levels, which is needed for survival in sepsis. And as you know, there is a distinct entity in sepsis called post-sepsis immunosuppression, trying to look at CD4 cells to determine. Not every patient will go into post-sepsis immune suppression, which we call it as CAIRS, CAIRS, compensated anti-inflammatory response syndrome, or post-sepsis immune suppression or immune paralysis. So people are looking at doing certain cell ratios, like how in COVID we used to look at lymphopenia and the neutrophil sort of a ratio, all that as a markers. In sepsis, they are looking at these as tools to recognize patients who don't survive despite your best efforts. And these are the cohort of patients where you would see that you have gotten over, you have treated the infection, bug is gone, all cultures are negative, but they just don't recover from multi-organ dysfunction state. And they just don't recover. And then they'll have secondary infection and they die. You would see that very often in this. So these are the patients which we are increasingly trying to recognize by doing HLA-DR, by looking at even the ATP production. We are looking at the CD4 cell counts, interferon gamma levels, so on and so forth. They are looking at multiple variables. And what this is leading us is to look at immune activation drugs with sort of immune therapy. Like how in COVID, see, all this is a representation of multiple things we did in COVID. In COVID, we started using immune therapies, isn't it? We use monoclonal antibodies we started using. And now in sepsis, they're trying to see whether monoclonal antibodies have a role, and they're even using GCSF. So all these small trials are happening where now you would very soon get all the maps, like how in onco we are using. We may very soon have certain maps against certain specific pathways in sepsis. So there's a lot of advances, and AI definitely is here to play a big role. And AI would give you a trajectory as to what sort of a treatment algorithm that you need to follow. What are the innovative drugs that you may have to position based on certain parameters in a very dynamic way. We would have AI suggesting to us or giving us a props as to maybe we have to follow this pathway. Maybe this is a cohort of patients where we may have to use extracorporeal circulation. Maybe this is a cohort of patients where we may have to use immunotherapy, so on and so forth. So these are the advances that are happening, but the buzzword is the phenotyping. So, and the precision treatment, what we are calling. So this is the newer areas which will increasingly emerge, and the markers for this. And I'm sure you have heard of EGLs, endothelial glycocalyx end products. There's a lot of research happening. There are at least hundreds of EGL end products, endothelial glycocalyx end products, and they're like peptidoglycans and so on and so forth. So they're looking at these as markers, early markers of which are the patients who would deteriorate to go into organ dysfunction. So EGL end products are something they're looking at to very early on recognize the patients who would go into organ dysfunction and prevent them from. So these are all the advances. So you can go and look into some of the talks I've given, or look, there's a whole ocean of literature on this.
Yes, sir. Sai, sir, any comments from you, sir? Any final comments?
I think Dr. Pradeep has summarized, but as far as this case is concerned, I think it's been what we need to understand is picking them or triaging them in the initial part is very important. Subsequently, resuscitation part is with some whatever parameters we are using, CRT or lactate, that we follow it. And then subsequently, when to stop resuscitation, I mean, when to stop fluid and when to introduce pressors. So these are all very critical decisions. Subsequently, de-resuscitation is one important part that also we need to give importance to. And then giving antibiotics in time, collecting cultures, and then subsequently de-escalation. So all these things simultaneously we have to keep in mind in managing a case of sepsis. I think if you follow the guidelines properly, probably most of the times you will be on the right track.
Thank you, sir. I think it was a wonderful discussion, sir. Thank you very much for providing your clinical insights, and it was a very good discussion and very beneficial. I think around 120 people logged in. Thank you, Dr. Pradeep Rangappa, sir, and thank you, Dr. Sai Prasad, sir, for coming on to board and giving your valuable time and teaching students. And thank you, Dr. Shravan and Dr. Shushmita, for bringing out that case, which led to a very good discussion. So thank you, sir. Thank you.
Shravan, good luck to Shushmita.
Thank you.
Give your theory exams that happened 1 week back, I think.
They are in IDCCM, sir, actually.
No, IDCCM theory happened, no? Just one.
They are actually joined 3-4 months back, actually.
Okay, okay. Because I was told the paper was a little difficult. I don't know what
Yes,
you
sir. Yes, sir. Yes, sir.
In Sai, did you hear anything on that?
Yeah, yeah.
Mm-hmm.
So maybe Sai set the paper. Okay, good.
Thank you, sir.
Okay, thank you. Thank you.
Good luck.
Thank you, Sai sir. Thank you, Pradeep sir, for being there. Thank you.
Yeah, thank you, Venkat.
Good night.
Good
Good night.
Good night.